So, good morning. We will officially open our Pancreas Symposium. Today, we are very, very, very honored to have the top Brazilian surgeons. And our conference will be about pancreas cancer and vascular resections. And for so, we have invited as panelists Dr. Adriano Sampaio, who is from São Paulo, who is a Brazilian known HPB surgeon who does a very special uh, job, I would say, in São Paulo. Thank you for being here today, Adriano.
Thank you, João. Thank you for your invitation. Very honored to discuss this topic with my friends, panelists, and with Professor Büchler. Very nice to meet you again. I've been in Heidelberg, and by the time you were there in 2015, I think, and I've learned a lot. Thank you for sharing your knowledge and also your experience with us, Professor Büchler.
And the other panelist is Dr. Alexandre Rezende, HPB surgeon from Minas Gerais, and he's an expert in robotic pancreas resection, and also he has a very important congress and a course in Barretos, where they perform all kinds of knowledge in the HPB surgery. So thank you, Dr. Alexandre. You're muted. You can hear. Oh.
My pleasure, John, and it's very honored to have the opportunity to discuss the session with Professor Markus Büchler. He's an icon, and we are very anxious to hear what he's bringing us about the vascular resection. His talk will be fantastic, I'm sure.
Thanks. And as clinical oncologist, partner here from Curitiba, Dr. Evanios Wirman. Welcome, Dr. Evanios. Thank you very much for being with us here this morning.
How are you, John? How are you, everybody? I'm nice to be here with you, and I'm very glad to be here and join this session with you folks.
Thank you as well, Dr. Felipe Borges from Portugal, to be here for all kinds of support. And thank you very much. We've been talking during the week. For any problem that we had with the transmission, that you would be here to help us too. Thank you very much indeed.
My pleasure.
And Professor Markus Büchler from Champalimau Foundation, certainly one of the greatest world authorities on the pancreatic field. Thank you very much, sir. Wir freuen uns sehr über Ihre Anwesenheit auf unserem Kongress. Dankeschön. Sehr. And I hope we're gonna have a very nice conference. And anytime you want to start it, thank you very much, sir.
Okay, João, thank you for introduction and thank you for all the kind words. I love Brazil and your country, and particularly I know very well the Southern American ability of do demanding surgery. I have seen surgeons in Southern America, in Brazil, in Argentina, doing excellent surgery. So you have something that we also have in common. Thank you for inviting me. And today we will speak about pancreatic cancer surgery and the evolution of pancreatic cancer surgery is that we all learned that it has to do with the vessels, and to do good pancreatic cancer surgery, to do curative pancreatic cancer surgery, we all have to become vascular surgeons. And from my training, I'm a vascular surgeon because the old generation general surgeons were also trained in vascular surgery. Nowadays, the young surgeons, they have to take a special course in vascular surgery, or they learn it from their teachers that are able to do it. But for sure, the future of demanding pancreatic cancer surgery has much to do with vascular replacement. So let's start with the standard of care in the year 2025. If the pancreatic cancer is resectable, then we do surgery plus adjuvant treatment. Can you see my curve?
Yeah, perfectly.
Okay. And if it is not resectable, then the standard of care is neoadjuvant treatment plus surgery later. But surgery is not surgery, ladies and gentlemen. Surgery nowadays is this kind of surgery. You see here, after resection of the pancreatic cancer, the aorta, and then you also see here a renal artery that has been resected because the cancer was extending to the left part of the body, and then you see the superior mesenteric artery as well as the celiac trunk. So this is kind of pancreatic cancer surgery of today. Just another example. Do not forget, and I'm very happy that we have an oncologist with us today, Ivanios, my pleasure. We should never forget that the only curative treatment in pancreatic cancer is surgery. This is very frequently forgotten, that surgery can cure all the other measures, such as chemotherapy, radiotherapy, immunotherapy. They can contribute to the cure, but at the end, it needs surgery. We should never forget this. Now, here you see an image of the triangle, which I would like to make you familiar with. The triangle is the field in between the superior mesenteric artery, the celiac trunk, hepatic common artery, as well as the portal vein, superior mesenteric vein. This is the triangle. And we have learned that within the triangle is most of the local recurrence, and therefore a pancreatic surgeon who is doing surgery of pancreatic cancer has to clean the triangle. Very unfortunately, most of the pancreatic cancer surgery around the world at the end of the surgery does not look at this image. Most of the surgeons never see this triangle, and we have to teach the surgeons to see the triangle at the end of the operation. I will speak about more in a minute. It's just another experience after the resection. Here you see the pancreatic left side, superior mesenteric artery, celiac trunk, portal vein, and if you lift up the portal vein, you see the triangle. This is just another experience. I want to make you familiar with this place, and I will tell you very clearly why. And if you see this again, it is really a triangle. So we speak from the triangle because it is a triangle. You see the superior mesenteric artery, you see the celiac trunk, common hepatic artery, and the portal vein, superior mesenteric vein, with an end-to-end anastomosis that has become very frequent. In pancreatic cancer, we do 50% vascular replacement meanwhile. Then you also see the inferior vena cava and part of the renal vein. So this is our planes where we operate nowadays when it comes to pancreatic cancer. Here you see the bile duct that has been clamped until reconstruction, and the left side of the pancreas. I think everybody now understands the triangle. Now I tell you the definition of the operations we do meanwhile more recently. It's either single vascular replacement or dual or triple. If you are able and willing to do triple, there is not much left that is so-called not resectable. So if you are willing and if you are encouraged to remove and replace the superior mesenteric artery, the celiac trunk, as well as the vein, then you have the situation where you can resect most of the locally advanced or not resectable pancreatic cancer. So here you see a single vascular replacement. You see this end-to-end anastomosis, superior mesenteric vein, portal vein. And the experienced surgeons in the room, they immediately see that this is a mistake because the surgeons have produced a small stenosis. This will not be relevant, ladies and gentlemen. The flow is very high, although there's a stenosis, but the radiologist, they will tell you in the post-operative imaging that there's a stenosis, and you will not like to hear this. And next time I teach my surgeons to do a so-called growth factor, which is 1 centimeter, to make the vein able to enlarge so that it doesn't look like that. But this is a single vascular reconstruction, pancreatic cancer resection. So artery is much, many surgeons are much afraid to do arterial reconstruction. And I remember very well my first and my second and my third, and I was as afraid as any other surgeon in the world to do it. Meanwhile, it has become standard of care, and I would encourage you to do it. The sooner the better, because everything has a learning curve, and the learning curve in vascular replacement and pancreatic cancer surgery is something like 20 cases. So the sooner you start, the better. We have been one of the primary surgeons recommending the splenic artery for vascular replacement. I have to say that the splenic artery is an ideal vessel to reconstruct either the superior mesenteric vein, the celiac trunk, the hepatic artery. So therefore, become familiar with the splenic artery because it is, I always say, it is by God for us to use it to replace arteries because it is such a nice vessel and it is long enough to do whatever reconstruction you need. So this is just an example. This is a dual reconstruction. You see the portal vein, superior mesenteric vein, and then you might see here the patch on the left side of the vein. I have used a piece of the renal vein to put this patch on here. Sorry that you don't see more. And this is the splenic artery here as an interposition between a little stump of the celiac trunk and the common hepatic artery. So this is just a piece of the splenic artery. And as I told you already, the splenic artery is an ideal reconstruction vessel, and you have it in practically all your patients when it comes to a pancreatic head cancer or a locally advanced pancreatic head cancer. The splenic artery in most of the cases is, you can take it. This is another dual here. You see the portal vein, superior mesenteric vein end to end. Here you don't see a stenosis. So this was a well done portal vein anastomosis. And then in this case, you will not see well, there was a replacement of the celiac trunk to the celiac trunk. Arterial resection was one of our special interests. We have published this series about almost 400 arterial resections in pancreatic cancer, and you might read this article. I will not go into detail. I must say that in Europe, we were one of the pioneers to do this. We should never forget our friends from Japan, because they were the real pioneers in doing artery reconstruction in pancreatic cancer. They were the ones who did it first. We have been early taking over in Europe, and then finally and lastly, the United States of America, more recently, they also do it. They were very, very hesitating in the beginning to do it. Meanwhile, you can read many articles from the United States. I think Southern America were doing it in some centers quite early. Okay, this is a triple. This is what I want to lead you to. As you can see, this is an end-to-end superior mesenteric vein to portal vein. Nice anastomosis, no stenosis. There's a common hepatic artery reconstruction here, end-to-end to the stump of the celiac trunk. And there's an end-to-end superior mesenteric artery to superior mesenteric artery, 1.5 centimeter, that was involved, resected and reconstructed. And then you certainly also see the other vessels when you have cleaned the field. And this is a clean pancreatic cancer operation, a triple reconstruction. If you are keen to do this, then there is not much left that is not resectable. And for our friend Dr. Ivanus, this is when you have done 12 cycles of FOLFIRINOX, then the liver looks like that. The experienced surgeons know very well. This is the so-called blue liver, and this is the result of an intense neoadjuvant treatment. And we like neoadjuvant treatment because it makes many patients resectable that are regarded not resectable. Okay, this is another triple. So it might look like that, where you have reconstructed everything by the vessels of the patient, or you need other kinds of replacement. For example, this is a long prosthesis to reconstruct portal vein, superior mesenteric vein. It's a ring-enforced 10 millimeter. And then also here you see the hepatic artery celiac trunk was reconstructed with a 6 millimeter. This is a very fast, easy reconstruction because you just take the prosthesis from your wherever it is and put it in. And then you see an end-to-end superior mesenteric artery to superior mesenteric artery reconstruction. So this is another triple. And then you see the renal vein, vena cava, and the field is clean. So, ladies and gentlemen, summary until here. If you are willing and encouraged and experienced enough to do the triple, there is nothing left that is not resectable. In fact, it is not true. There are still some patients left that have, for example, an infiltration of the aorta, or it is more complex. The cancer grows into the tributaries of the superior mesenteric artery or vein. This is still the limitation for clean surgery. But principally, if you do the triple, there is not much left. Okay, just another example from, I think, last week. This is an Appleby, so the resection of the celiac trunk. And then you see here the splenic vein stapled off the superior mesenteric vein, portal vein. And then you would see on the left side here that the liver is being blood supplied by the gastroduodenal artery. You know very well the so-called Appleby reconstruction. Now, the special thing here is I could preserve the left gastric artery. When you have enough celiac trunk, then you can preserve the left gastric, which is not bad for the preservation of as much as possible stomach. So this is just last year, an example of a dual. This is the prosthesis to the vein, and the common hepatic artery was re-anastomosed to the celiac trunk here. So this is a dual, and this is just another example of an Appleby here, celiac trunk closed, pancreatic stump. The liver works via the gastroduodenal artery, and here you see the superior mesenteric artery after a divestment. So the complete tissue around the artery is cleaned. And then here you see a vein interposed. This is the superior mesenteric vein. This is the portal vein, and the interposition has been done by a gonadal vein. So this man had a big gonadal vein, and I took it and put it in here. And the message for all of you is the human body is full of veins. When you open the belly, you have many, many veins that you can take as a replacement. So don't be afraid by thinking, oh my God, where's my replacement? Where's my vein? Do I have to take the jugular or the safena? You have many veins in the belly that you can easily take. So when you have to do a vascular reconstruction, first look into your belly, whether the gonadal vein, the ovarian vein, the inferior mesenteric vein, the left gastric vein, whatever is big because of the portal venous obstruction, whatever is big vein you can take to replace. And certainly also the left renal vein is a wonderful vein for replacement. So forget about being afraid. You have many, many, many vessels that you can take easily to replace. Just another example, this was a dual here, common hepatic artery back to the celiac trunk end to end, the arterial divestment along the superior mesenteric artery, and here's an interposition of a left renal vein in between the superior mesenteric vein and the portal vein. So the left renal vein is a wonderful vein for whatever replacement you need, and this is a dual reconstruction, ladies and gentlemen. Single, dual, triple. Okay, this is from Mayo Clinic recently, as you can see here. This is another triple. You see the patch on the portal vein, and then you see the prosthesis put on the aorta, one arm to the hepatic artery, one arm to the superior mesenteric artery. So this is kind of a triple reconstruction. Don't be afraid to take prosthesis. We have published that they have a long-term patency. There was a kind of a fear that these prostheses would not stay open. This is not correct. If you do the right technique, they will stay open. We will discuss this. Okay, question number one. Is surgery contributing to cure? This is data from '89. You see from Michelasi, who worked that time in New York, the 5-year survival after surgery for pancreatic cancer, 5%. This is our own data from 2017, the 5-year survival after surgery plus adjuvant chemotherapy, close to 30%. And this was a multicentric trial, 700 patients. So this is not a single institution. This is a multi-center achievement, 30% 5-year survival after pancreatic cancer surgery. So question, has surgery improved? Yes, dramatically. We can help patients by surgery plus neoadjuvant or adjuvant chemotherapy. So what is the issue of 2025, ladies and gentlemen? The issue is we have to be honest and humble. Surgeons have to be honest and humble, ladies and gentlemen. Local recurrence is the #1 problem. And please see this data. This is our own data from SPAC4. Remember, John Neoptolemus and myself, we have founded SPAC, the European Study Group for Pancreatic Cancer, and we are running randomized controlled multicenter trials in a row. This is SPAC4. We randomized 730 patients. And what you can see here, the local recurrence was 33%. And if you take local recurrence plus distant metastasis, this is another 7%. So the local recurrence in this trial was 40%. So ladies and gentlemen, my friend surgeons, if you do a colon cancer resection, you have a local recurrence rate of a maximum of 3%. And you will be happy with that because this is good surgery. But a local recurrence rate in pancreatic cancer of 40%, ladies and gentlemen, this is a disaster. And our friend Ivanus, who is our friend, he will never say that, but he will believe this, that this is not a good outcome after surgery. This is just not good enough. So we have to improve. See this example, ladies and gentlemen. This is 3 months after a so-called radical Whipple for pancreatic cancer. You see something here around the vessel, and the radiologist will tell you, this might be fibrosis, this might be. But after 6 months, this is more prominent, and after 9 months, everybody can see it, that this is so-called local recurrence. But we have to be honest, ladies and gentlemen, this is not local recurrence. Recurrence is, by definition, if you have removed and it comes back. But this is local persistence. This has not been removed adequately, and so then it grows further on, and you see it very prominently after 9 months or earlier. So this is the main problem for us as pancreatic cancer surgeons, ladies and gentlemen. And to overcome this problem, we have to operate on more radical, and this means more vascular surgery, but this also means more perioperative treatment, i.e. chemotherapy, either before or after the surgery. Together with radical surgery, this will bring the good results. So we have been coming up with a triangle operation. Our first publication is 2017. I would like you to read this. I don't go into detail. But this is a typical situation for a triangle operation. This is the radiology after 12 cycles of FOLFIRINOX. And everybody would say this is not resectable. And you sit in your multidisciplinary conference and your radiologist, and everybody will say, yes, not resectable, yes, not resectable. So when I travel around the world, I'm sitting in these many multidisciplinary conferences, and it is always not resectable. And then they say, oh, today we have the privilege, Professor Büchler is here, he has so much experience. And then I have to say many times, resectable, 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 resectable. And this is causing a lot of trouble in these institutions because they say, do you tell us that we are not doing the right thing? And then I say, no, I would never tell you you are not doing the right thing, but I have to say this is resectable. Okay. And this is the situation after a triangle operation, and this is the same patient. So after neoadjuvant chemotherapy, these results, these imaging results, are no longer telling us that this is not resectable. Most of this is easily or not easily resectable after neoadjuvant. You can do either end-to-end here and end-to-end here, plus a divestment of the superior mesenteric artery and clean the triangle, that the cancer comes off much easier after neoadjuvant treatment. So please, message number 2 is images after neoadjuvant chemotherapy are no longer telling you it is not resectable. Most of these cases are resectable. Now, I spoke about arterial divestment. After neoadjuvant chemotherapy, many patients can just be divested. You see here an end-to-end replacement with a graft, but then you see the superior mesenteric artery here under a big bulk of so-called cancer, And if you go into the right layer on the superior mesenteric artery, or even under the first layer of the superior mesenteric artery, our Chinese friends were the pioneers to do this, then this will come off quite easily. And at the end, you have this specimen here that has shown you where the superior mesenteric artery was, and you have a clean divestment of the superior mesenteric artery, because the cancer was no longer really at the wall of the superior mesenteric artery. You might find cancer cells within this bulk that you have removed, but not on the wall. If we find cancer on or in the wall, then we resect. But you can do divestment regularly. Okay, triangle operation. This was our next publication in 2021. This was the first proof that the triangle operation makes sense. When I came to Lisbon 5 years ago, we immediately started to investigate this further, and we investigated the tissue that we remove from the triangle. So this tissue that is normally not removed by most of the surgeons around the world, we investigated. And not to your surprise, ladies and gentlemen, in 1/3 of the patients where we investigated the triangle in pancreatic cancer, within this bulk of tissue of the triangle, 1/3 of the patients have cancer cells within the triangle. So I'm sure this is plausible for you. This makes sense to you that if you leave the triangle, if you do not clean it, then you get a local persistence rate of cancer of 30% that is later being diagnosed as local recurrence. And the cancer is in the lymph nodes, within the triangle, 40%, within the fibroadipose tissue, 50%, within the perineural tissue, 30%, and within the lymphovascular tissue, 24%. So the cancer in the triangle is at different places. The first group that has studied then the triangle operation in a prospective fashion was this Chinese group from Shanghai. They are well experienced. They are compared 50 patients with the triangle operation versus 50 patients with the standard Whipple. And they found out that local recurrence went down from the usual 30%. It's always 30% down to 8% in the triangle operation, and the overall recurrence, including metastasis, went down from 50% to 18%, and the overall survival went up dramatically after the triangle operation. So this was the first proof that the triangle operation, together with chemotherapy in all of these patients, is increasing the survival. So why you have invited me today has much to do with my experience. This is my Heidelberg time. Many of you were there to see what we do, 13,000 pancreatic operations. Most of it was for cancer. And we did 10,000 pancreatic resections. Most of it were pancreatic head resections, pylorus preserving, pylorus resecting, classical Whipples, and bigger operations. But we also did 5,000 left resections. Total pancreatectomy has undergone a revival. We do this regularly if it is necessary, and 1,000 other pancreatic resections. So we have experience, ladies and gentlemen. The reoperation rate was 9%. The pancreatic fistula rate B and C was 9%. And the in-hospital mortality in this 10,000 patients was 2.9%. Not bad, but it is possible to do better. Since 2023, I formally work in Lisbon. I was very proud to be recruited to lead this pancreatic cancer center, which is a very modern center. You can all come to visit us and see what we do. This is the only center in Europe that singularly focuses on pancreatic cancer diagnostic and treatment. So since I have taken over the lead there, we have operated on 800 patients. Most of it is pancreatic cancer, again, neuroendocrine, IPNM, etc. Most of what we do are pancreatic head resections, 50%. 27%, meanwhile, in all the pancreatic surgery is vascular resection, but in the pancreatic cancer patients, this is 47%. So every second patient, when we do pancreatic cancer surgery, needs vascular resection, and 17% multivisceral. Pancreatic fistula rate, 15%, has slightly come up in Lisbon as against Heidelberg. Post-pancreatectomy hemorrhage, 9%, bile leakage, 3%, delayed gastric emptying. ICU stay 2 days, hospital stay 10 days, and our in-hospital mortality has gone down to 1% because we have learned better to deal with the complications. You see major complications, 27%. The secret of success in pancreatic cancer surgery is to know how to deal with the complications. Everybody has major complications in pancreatic cancer surgery, but you know how to deal and not to hide and not to wait, not to say, oh, let's see tomorrow. Maybe we can wait until tomorrow. Pancreatic cancer surgery complications have to be dealt with immediately, ladies and gentlemen. Immediate CT scan, immediate intervention to avoid the catastrophe. Very important. Surgeons tend to wait. We are all surgeons. I do the same. I try to say, let's see how he is tomorrow. This is not the right decision in pancreatic cancer surgery complications. Okay, I have spoken now for 30 minutes. Maybe we take 5 minutes more. I go straight into the point. You see, this is our own data, pancreatic cancer surgery. If you do the right thing, the right operation, you will reach a 40-40. This is 40 months median survival and 40% 5-year survival. And the right thing is neoadjuvant or adjuvant chemotherapy plus the right surgery. The same is true for, by the way, distal bile duct cancers. The right operation versus the R1 or the R2 or whatever, this is the right radical operation, is leading to a 77 months median survival in distal common bile duct cancer. And the same is true for ampullary cancer, very good 5-year survival of 70% when you do the right operation. We have developed many techniques. I cannot go into detail. Artery first, uncinate first, the triangle, different types of vascular resection, arterial resection. You will do this more in the future. Artery first. Whenever we have a involvement of the artery, the first step is go to the vena cava, left renal vein. Above the left renal vein is the superior mesenteric artery. We free this to know where we have to go and where we have to arrive after the pancreatic head resection. It gives you much more safety when you have encircled the superior mesenteric artery as your first step. Uncinate first, I don't go into detail. Locally advanced, 600 patients published recently. It is certainly not resectable in this situation, but it becomes resectable with very good neoadjuvant treatment. Either FOLFIRINOX or Gem-Abraxane is equally effective, and we see many patients that have a wonderful downstaging. Here comes something for the future, ladies and gentlemen, conversion. Many oncologists put the patients into boxes. So liver mets, lung mets, the patient goes into the box palliative treatment. And this is not okay and also not fair to every patient, because many of them can be converted to curative treatment. This is a series about 173 patients that by neoadjuvant treatment we could convert to curative surgery because they were downstage, no more liver mets, no more lung mets, primary tumor downstage, and they could go to a curative operation with quite a good outcome, ladies and gentlemen. So let us not put the patients into boxes, rather than try to make the patients resectable and curatively approachable. We were the first to show that adjuvant treatment is helpful. This is SBAC 1, New England Journal 2004. And we were all surgeons, ladies and gentlemen, doing this. And we were following up with this with SBAC 4. This is SBAC 4, adjuvant gemcitabine plus capecitabine, 40% 5-year survival in a multicentric approach. So it works. I finish up, ladies and gentlemen. This is the conclusions, pancreatic cancer surgery in 2024 and 5. For sure, we need multimodal oncologic surgery. So either neoadjuvant in the non-resectable or adjuvant in the resectable pancreatic cancers. We have to prevent local recurrence. This is our big task of the surgical group in the future. Prevent local recurrence, by that increase the survival and the outcome of the patients. Increase resectability by neoadjuvant treatment. Improve early surgical outcome by not wait and see when you have complications. And by all of this, improve the survival of our patients. It has been my pleasure to lecture to you. Thank you very much.
Thank you very much, sir. This was an outstanding presentation. Yeah. Dr. Orlando Torres is with us now, and he's also one of the world-renowned authority in the field. So
Joao,
as you see,
can you do me a favor?
Sure.
Because I'm sitting in a car and it is quite inconvenient.
Sure,
Can we
sure.
do my discussion now and then I step out? You
Sure,
would do
sure,
me
sure,
a
sure,
great
sure.
favor.
Okay. So I'm going to invite Dr. Torres to start the discussion with you.
Yes, please. Hello, Orlando, my friend. We cannot hear you.
Orlando, you're muted. Still? Maybe Alexandre could start while Orlando unmute him.
For sure. Congratulations, Professor Büchler. Fantastic experience, and your job is amazing. All of us, most of what we're doing today is what we learned from you in your papers, in your very fantastic experience. For sure, there's a lot of issues I would like to discuss with you, but I will select a little bit some things are more important, I think. First of all, for this, I've been doing this triangle operation, all kind of vascular resections, and for me, the venous resection is a standard of care, and I'm no doubt about it. The arterial resection, I think for me, the key point is to select the patients. Is that a good selection is the key point. I don't think any kind of patients will tolerate this kind of resection. You have to have a very well fit patient to do it. And for example, CI 19.9, very high levels, leaving us the impression that they may have distant metastasis. How do you select these patients for this kind of arterial resection? And if you do radiation, neoadjuvant chemoradiation for this kind of arterial resection. Once you've shown us there's not only the arterial invasion itself, but the periarterial tissue, this perineural, this fibro tissue that's connecting with the vessel that's frequently positive for the tumor. So do you do chemoradiation for this kind of arterial resection? And do you select them, for example, by high level of 19.9 patients? Would you consider to resect these patients? Thank you.
Okay, Alexander, the answer is you're absolutely right. Patients for arterial resection should be well selected. So our standard of care is venous involvement is not an exclusion for immediate surgery, but arterial involvement.
Certinho. Obrigada.
Arterial involvement.
Ok. Quiser levar o cupomzinho? Não?
Orlando, now we hear you, but we also hear your beautiful lady.
Alô, meu nome. Alô? Professor
Sorry.
Büchler.
Alexander, wait a minute. I have to answer to Alexander. So arterial involvement is always an indication for neoadjuvant treatment. Always. However, we never do radiotherapy because we have published and we found out that radiotherapy is an excellent measure in many cancers, but not in pancreatic cancer. In pancreatic cancer, there is no data at all that show that radiotherapy makes it better. Therefore, we do not do radiotherapy, neither neoadjuvant nor adjuvant radio. But we use good chemo, and chemo helps us a lot. So the selection is every arterial involvement will undergo neoadjuvant treatment for at least 3 months and a maximum of 6 months. The CA19 by itself is not an indication for anything. So if we have a resectable cancer and a high CA19, we go for surgery. But if we have liver mets and a low CA19, we go for neoadjuvant. So the CA19 by itself is not an exclusion for surgery. And then the question finally about arterial resection. I must tell you, Alexander, you are very experienced. So my experience is the more I did, the easier it became to do it, not by technique, but by indication. Because we have huge respect as surgeons. We have huge respect to do an arterial resection and reconstruction. And this is okay. But experienced surgeons should lower their respect because the outcome is good. You will see the more you do, the more you see that the outcome is good. I tell you, in the beginning, I never did a pancreatic anastomosis when I did a arterial resection. Meanwhile, this is no longer true. I do an arterial resection and a pancreatic reconstruction because total pancreatectomy has a bad life quality. So the indications and the freedom to do it have become much bigger. And I would encourage you to do it more often because you will see that the outcome is good.
Just a reply about quality of life. In my patients with SMA resection, they presented with a very severe diarrhea and post-operative that impacts on their quality of life. Do you have any tip for getting better this on post-op?
Yes, I have some tips. First of all, I tell you a little joke because once I went to a big international meeting and I showed our 30% diarrhea after radical surgery. And then a famous surgeon went to the microphone and said to me, listen, professor, this is not good surgery. In our institution, we have 0% diarrhea. So my reply was, then you have never done the right operation when your diarrhea is 0%. Okay, he hated me after this, but there is a lot of truth in it. If you have diarrhea, this is kind of a proof that you have done the right operation, number one. Number two, diarrhea can be really painful for the patient and for the surgeon. So our principle to treat diarrhea is, first of all, pancreatic enzymes, number one. Number two, deal with the gastric acid, omeprazole every day, because the gastric acid will kill the enzymes, as you know, and then the enzymes will not work. So omeprazole, a lot of pancreatic enzymes, and this is in between 300,000 to 600,000 units per day. It's much more than most of the surgeons apply. Number three, Imodium or something like that to decelerate the bowel activity. Number four, there's a lot of other anti-diarrheal drugs, and the patients have very good networks to advise each other against diarrhea. Most of the diarrhea is disappeared after 2 to 3 months. Unfortunately, there are 10% of our patients with ongoing diarrhea, and this is bad for them. However, they live with this, but there is a percentage of patients that have ongoing diarrhea.
Thank you very much, Professor.
Orlando, would you like to ask now?
Yeah, it's okay. First of
Orlando, my friend, you're
my
also in
friend
the car.
Professor. Yeah, I'm also in the car. We are in the car. So, Professor, first of all, thanks for your fantastic presentation. Amazing presentation. So, I have two quick questions. Of course, I spent like 10 days with you in Heidelberg in 2018, and I learned a lot with you, of course. So, I have two quick questions. First of all, I spent 3 days with Professor Hackert last week in Belgrade. I asked him about divestment. We know now that there are at least two kinds of divestment: the periarterial divestment and subadventitial divestment. He told me that he don't do subadventitial divestment because the high risk of pseudoaneurysma in that case. I ask you, do you do routinely, if necessary, at subadventitial divestment or just periarterial divestment?
Yes.
The second question is...
Let me answer the first question, Orlando.
Okay.
Okay. So the answer is, I do periarterial divestment, okay? Because you know very well, if you really go subadventitial, the artery looks like that it will blow up in 10 seconds. So we don't like this as surgeons, and you are absolutely right. However, and we have to be fair to our Chinese colleagues. Our Chinese colleagues, they say that you can go, or other way around, the adventitia has at least 3 layers. The adventitia has at least 3 layers. So you can easily go under the first layer of the adventitia. So not just under the adventitia, but let's say in the adventitia, and then travel in this layer. I must say that this is not for me so far an option, I must say. But we have to be fair to our Chinese friends. They say this is possible. I don't do this because more or less you run under the adventitia and then you have the blow up. But the periadventitial works very well.
Thank you, Professor. So, I asked for you the same question maybe 2 or 3 years ago in Miami. So, I've seen your first slide about the triangle operation. What do you think about the minimally invasive surgery like robotic surgery doing triangle operation? Because I don't see any videos with the triangle operation in robotic surgery, and rarely to see triangle operation, because I know the triangle operation is the treatment of pancreatic adenocarcinoma. Could you tell us what's the future of robotic surgery for that radical dissection,
Yeah.
including triangle operation and vascular resection?
Yeah. Orlando, the answer is you are right. At this moment, the robotic surgery is not developed so far. So at this moment, I see all these wonderful videos of the robotic surgeons, but I never see a triangle operation. I don't see an arterial reconstruction, but I expect that in some years from now, the robotic surgery will be developed into that dimension, because when you speak with the experienced robotic surgeons, they tell me, Markus, I know that so far we do very little of this, but we try to go into this field. So I think in some years, the good robotic surgeons will do this. They will develop techniques to do it robotically. So far, it is not developed.
Thank you,
Can I,
Professor.
But
can I,
I'm critical when I see the robotic surgeons, and then there is this enthusiasm in the room, and everybody's so happy, and everybody. Then I say, listen, guys, this is not the right operation you do, and then it becomes unhappy in the room. But there is very good robotic surgeons that say all of this is learning curve, it's under evaluation, and we will develop, and it needs some more time, and then we do it. And I'm convinced about this.
just a
Thank you,
small
Professor.
comment on this. You've published recently the Europa trial. And in the Europa trial, on the robotic group, 50% of the patients are supposed to have the triangle operation performed by your own papers. So you're kind of contradicting your own paper on this comment, Professor.
Yeah. I tell you, do you really ask me this or not?
Well, I'm telling you, you've published that 50% of the patients you've done robotically have done that. I do robotic, and I do the triangle operation on robots, and I think it's possible. It's effective, and your own data have shown this.
Yeah, Alexander. Yes, the pure triangle operation, if you have enough experience, the pure triangle, so to clean the triangle, yes, but to do the vascular reconstruction, single, dual, or triple, this is the limitation. This is the limitation of the robotic. So to clean the triangle, I think that the experienced robotic surgeons can do it. But you know very well that if you move forward, you can happen into big problems when the vessels are involved, when you go robotically.
For sure, I completely agree. I
Okay.
don't like robotics for reconstruction, except for small reconstructions. For large reconstructions, I think open we will do better. But for the triangle, I think that for tumor that does not have need for vascular reconstruction, we can do a very good operation on robots.
I would
Yes,
like to
I
invite the
agree.
oncologist to discuss with you now, sir. Dr. Evanius. Sorry to interrupt you.
Ivanovich, we cannot hear you.
Sorry, sir. I just said that I would like to invite the clinical oncologist to make some points on your conference. Dr. Evanius? He's muted. You're muted.
No problem.
Oh,
Now,
okay, okay. You can hear you now.
here,
Yeah, yeah,
here.
yeah.
Now we can hear you.
It's all my pleasure to be here with you. I'd like to congratulate Professor Büchler on your speech, and I'd like to say that I'm an enthusiast of neoadjuvant chemotherapy for patients because here, especially in Brazil, we have very difficult to propose adjuvant chemotherapy for some patients in the adjuvant setting because the patients are very poor in this kind. So neoadjuvant makes us not just the question of the conversion of patients, but the possibility to administer to patients the chemotherapy in a good fashion. I'm not a fan of longer chemotherapies. I do think that shorter chemotherapy is like 3 to 4 months. And now we have more potent chemotherapies that also can prevent the liver to be damaged, like nalirifox with liposomal irinotecan, and then we could promote more efficient chemotherapy that could improve not even survival of patients like we recently have seen with the Cassandra trial. And it's a very good option for us. And for sure, the question.
Ivanois,
So,
I know all. Allow me to answer because I know all the arguments. So let me give you some arguments. Number one, I agree with you that every patient who is not resectable should be made resectable by neoadjuvant treatment.
perfect.
There is no discussion about this. Now the discussion is about resectable patient. There are in the literature, as far as I know, 11 or 12 randomized controlled trials that have been done by oncologists, so not by surgeons, have been done by oncologists that have shown that neoadjuvant is not effective in resectable pancreatic cancer. So the evidence is very clear that resectable does not take advantage from neoadjuvant. I can only say this is the evidence level 1. And so I'm used to oncologists that they would accept evidence level 1, but I meet with very many oncologists that do not accept this. So I think we have to follow what is the literature telling us, namely that there is no evidence for neoadjuvant in resectable. So this is number one. Number two, I have never seen 5-year survival rates of over 40% after neoadjuvant treatment. However, I have seen 5-year survival rates of over 40% regularly after surgery plus adjuvant. So the 5-year survival rates that have been published are much better after surgery plus adjuvant than after neoadjuvant plus surgery. So therefore, there is this big controversy, and I agree that this is a controversy, but there is no data for neoadjuvant in resectable pancreatic cancer. And I tell you, if the surgeons would have done these trials, I would have said, okay, there's bias, the surgeons don't like it, but you have done the trials that show that there is no effect in the resectable patients. So I believe this data.
I do agree with you. I do agree with you. The level 1 evidence, it's adjuvant trial. It's adjuvant trial. But you cannot perform adjuvant treatment to all of patients.
Why? Because your patients have so many complications. The Brazilian patients, so that you cannot go for adjuvant. Or what is the reason?
We have a lot of reasons like lacking of performance status and frailty of patients and toxicity. And we have a lot of complications that do not allow us to give us patients the proper adjuvant treatment for the patients. And I do agree with you that level 1 evidence, it's adjuvant treatment. But there's no question that chemotherapy is improving a lot. We're learning a lot about newer molecules of KRAS or BRCA and other features of the cancer that allow us to provide more and efficient chemotherapy to the patient, and also discuss with patients something like you ever said similar to colon cancer, as Fabrice and Andrea have said. We now can cure metastatic pancreatic cancers with very good chemotherapy. We're discussing some trials that's where in the older where we use very poor chemotherapy, poor chemotherapy.
Ivanos, I agree with you. You have become so good, the clinical oncology, helping us surgeons so well, and we are so grateful. However, only surgery can cure. So whatever is the aim of any treatment should be to make the patients resectable. And you help us so much in that. And we are very grateful for what clinical oncology is doing for the patient. Okay?
Perfect.
You get a job. If you need a job, you get a job with us immediately.
Surgery is the cure. I do agree with you. But we're improving a lot. We're improving a lot the therapy for patients, because most of the trials that you cite use very old chemotherapy. But now we have Naliri-Fox. We have. I do agree with you that radiotherapy is no longer a very good option for patients, even in the adjuvant or neoadjuvant. But chemotherapy, a very good chemotherapy for patients, is for sure a very good way to treat our patients, even in the neoadjuvant or the adjuvant. So, but in neoadjuvant, I could deliver more easy and more efficiently my treatment. I do.
Markus, you are the man. I tell you, the more you tell me, the more I would like to have chemotherapy.
Okay. I'm doing my mission.
Just one question, Dr. Büchler, from myself. You showed one case where people said it was unresectable. These patients went through neoadjuvant therapy, and the image was still unresectable for most. So, and you resected. What is unresectable for you after neoadjuvant therapy? I mean, what would be a patient for you that like that one that went it was unresectable,
yes,
it went
very
through.
Important question, Joe. Very important question. So for us, under neoadjuvant treatment, not resectable is newly developed metastasis. So when under chemotherapy patients develop new metastasis, then they don't go for surgery. But the local situation, whether this cancer is smaller or whether the cancer is the same as before in the imaging, does not play a role. We go for surgery. So principally, we go for surgery after neoadjuvant in every patient who has not developed new metastasis.
Or it got bigger. If it
Or
remained
they got
at least
bigger,
the
or the
same, you would.
CA-99 is increasing considerably.
Okay. Dr. Adriano, would you like to make some questions?
Yes, thanks a lot, Professor Büchler. And I know you're in a hurry. You're very.
No, I'm not in a hurry. I'm in a car, and the oxygen is becoming lower, but it's still enough. Tell me.
Okay, I'm in the same question that João just asked you. Do you think that collaterals, venous collaterals, occlusion, obstruction of the venous flow to the liver, with cavernomatous transformation of the venous plexus. Is this unresectable for you?
Certainly not. Certainly not, because there are two options. Two options. If you have any vein in the hilus of the liver, any vein, then you can reconstruct by a long bypass or whatever. If there is no vein at all, then and only collaterals and only cavernous and no more portal vein at all, then my experience is that you can go without venous reconstruction, because you have the flow to the liver, and you can do your pancreatic resection and you will have flow to the liver after the surgery.
Okay.
So you have these two options. In practically everybody, you have a small stump of portal vein in the liver. And this you can use, you are liver surgeons, I know very well, you can use for a reconstruction. If there is nothing, only collaterals, only cavernous, then the patients tolerate the pancreatic resection without venous reconstruction. And then you might do a bypass from the supramesenteric vein to the cava or to the renal vein, so that the blood flow from the bowel is there if necessary. In many patients, you can just clamp and the bowel looks as before. So let's say the human organism is very clever. During the evolution of pancreatic cancer, the patient develop all these collaterals.
Okay.
And you can take advantage from these collaterals during your operation. Not everybody needs a venous reconstruction.
Thank you, sir. One of the greatest messages we got here from your lecture is that information that SPAC 4 just answered us, that we are not operating well on PDAC patients because we have very high local recurrence, up to 40%. And that is a message that I think we should deliver to pancreatic surgeons. We have to become better surgeons when talking about pancreatic cancer, because it's not acceptable to have such a high recurrence, local recurrence rate, which is actually not local recurrence but residual disease.
Yeah.
And
Yes.
thank you for
Cannot agree more. But you know, we surgeons are very proud people, and we have to become more humble in that regard, you know, that we say, come on, let's improve to make that better for the future.
That's right. And do you prefer doing a total neoadjuvant treatment for those vascular involvement patients, like with the whole cycles of whatever it is, FOLFIRINOX or gem-Abraxane? Do you prefer to do everything in the neoadjuvant setting, or do you restage the patient after a while and do pre and post-operatively?
Yeah, in most patients we do so-called perioperative. So we do 8 cycles before or 10 and 2 or 4 after the surgery. Because what we learned and what you see in all these new publications regarding cDNA in the blood, you know, the free cancer cells traveling in the body, in the blood, the patient definitely need an additional chemotherapy to kill these free floating cells. So therefore, we name it now perioperative chemotherapy, 2/3 before and 1/3 after the surgery.
So it's either 8 and after 4 or 10 after 2.
Exactly. And nobody knows whether it's 8 or 4 or 10 or 2. This is not been tested so far, but we consequently do before and after.
And one last question.
I do agree.
If I'm not wrong, I heard you just said in your lecture that when you have only vein involvement, you go surgery up front. You don't do
Exactly. The vein is not a contraindication for surgery at all.
But
The vein,
we know that
unless it is a 5 centimeter involvement, and the vein completely occluded, then we go for neoadjuvant. But a venous involvement by the cancer close to the vein or a small obstruction of the vein is not a contraindication for surgery right away.
I believe it's not a contraindication, but don't you think if you do neoadjuvant treatment, you have the possibility to have more negative margins, more R0 resections? Is that not true for you?
Adriano, do I think? I don't know. It has never been investigated, vein involvement, right to surgery versus neoadjuvant. So therefore, I don't know, but this is what we do. Arterial is our neoadjuvant indication.
Okay.
Ivanius.
Professor, and I hope I can visit you in Lisbon.
Come and see us. Everybody who wants, you're all most welcome.
Thank you.
Ivanius, one last question.
Oh, just consideration. I do agree with him. Not a very longer neoadjuvant, 2/3 of treatment up front, and then the third before evaluating ctDNA or free cell DNA. Perfect. Is the way.
Professor, for it's lunchtime. It's lunchtime in in Germany. So thank you very much indeed. You're a legend, a live legend. So we all would like to make you more and more questions the whole afternoon in Germany. But I know it's hot in the car, and you had your precious time with us. So thank you very much indeed, and I hope to meet you one day, or either in Germany or here in Brazil. I hope in Brazil. And thank you very much indeed for your precious time. It was really a great pleasure, sir. Really a great pleasure.
Thank you very much. You are all most welcome. Thank you for your attendance, and to everybody who heard this today. And my very good greetings to Brazil. Bye-bye. Next time when it comes to football, unfortunately, you will win because the German team is so bad. Okay.
Thank you, sir. And
Bye-bye,
thank you for all the
everybody.
panelists as well. Thank you, guys. Have a nice weekend.
Everyone.
Bye-bye.
Bye-bye.
Bye.
See you all. Bye-bye.
Bye.
We have our meeting in the end of the month of October. Maybe you can take the opportunity to come. It will be a good one.
When is that, Felipe?
Agora já podemos falar em português, eu acho. De 28 de outubro a 1 de novembro.
Adriano!
Ô,
Adriano! Bom ver você, amigo.
Bom
Eu tô
também,
vindo
amigo.
aqui de um triangle operation aqui em Santo André, cara. Não vai dar pra eu almoçar contigo aí, que eu já tô indo pro aeroporto aqui.
Uma
Pô,
pena,
grande.
uma pena.
Um abraço.
Conhece o Emílio?
A gente já se viu nos congressos. Tudo bem, professor Adriano?
Opa, tudo bem, meu velho? E você?
Tudo bem, tô aqui na Faculdade de Medicina da ABC.
Que legal, hein?
E aí, o doutor Orlando veio para operar conosco agora.
Tranquilo, a gente fez uma aqui. Precisava estar você para me ajudar, que eu não conseguia fazer o triangle operation direito aqui. Eu digo, pô, só Adriano vindo. Eu sei que é radical. Eu sou seu fã, Adriano. Tudo de bom, amigo.
Deixa de humildade.
Não vai dar para almoçar.
Humildade.
Não vai dar para almoçar aquele churrasco. Eu queria muito, mas já estou voltando. Tá,
Um abraço,
fica pra
boa
próxima.
viagem. Boa viagem.
Tá, tchau, obrigado.
Um abraço.
Essa aí é boa, né?